Thank you. It's great being here. It's fun being here amongst friends and being able to do this. A little bit different from a CROI audience. Who's been to CROI? Not just a few. Anytime. You know, it's a big audience. 4,000 to 5,000 people, and they only have 6 plenaries across the 4-day conference. So it was a little anxiety-provoking to prepare and deliver to a very biomedical, basic science audience on mental health. But, I'm pleased that it was well received. It was an honor to be asked to do it and to be the person to represent the mental health field in the context of HIV. So I let the audience know that it was an honor, and I also let them know that it was a little bit intimidating. And so I started off my talk by giving them the view of, when you look out, it's like about 2 football fields of sea of people. So I said, I'm going to share with you the view and what I'm looking at right now when I look out on the audience. And this is not where I have to point it. Ruining my timing.
I didn't mention anything about technical stuff.
It was...
How about your computer?
This is not attached. Well, luckily we have time, and there'll be time for discussion.
Can you just use the arrow in your...
This is not attached.
Oh, okay. Don't worry.
Okay. So that was the view they saw of what I was seeing when I was looking out on the CROI audience. And I have to say, as a clinical psychologist, I really don't understand why this is meant to be helpful. So maybe someone can explain that in the discussion. So in all seriousness, so let's talk about why focusing on mental health in the context of HIV prevention and care. Well, despite all of our medical advances, and there have been amazing medical advances in HIV prevention and treatment, we haven't fully achieved the goals that everyone had hoped for. We haven't attained them, certainly not as quickly as people had thought. Here we got the treatments, here we have PrEP. The epidemic can be over, right? We have significant gaps that remain all along the HIV care continuum. Mental illness, we know, influences every single step of that cascade and contributes to the gaps. People living with HIV have significantly higher rates of mental health disorders than that of the general population. And my proposition, I would posit that if we really don't seriously address mental health and really do better than we're doing, we're not going to get close to our global 90-90-90 goals, 90 people identified, 90 people in care, 90 people adherent and having viral suppression, 90%, or the ETE, end of the epidemic goals in New York State and happening in various places. I think that we're not going to get there if we don't really address mental health. And finally, the right to health needs to include mental health, not just physical health. The mind and the body are one, and I think we need to pay attention. So I'm going to talk about the challenges as well as the opportunities, the challenge being the global burden of mental illness worldwide, mental health and HIV prevention, the impact of mental health conditions on HIV health outcomes, and the challenges we face, but also the opportunities. There are strategic points, I think, for mental health interventions in the HIV context. We do have a cadre of evidence-based interventions that in our toolbox. I'm going to talk a little bit about the task in the context of scale-up, of task shifting, or some people call task sharing, as well as the concept of integrated care. So let's step back and look at the global burden of mental illness. This slide shows you the 2016 global ranking for number of years lived with disability per 100,000. And you can see that it's a measurement of burden of disease globally. Where does mental health and substance use fit in compared to other non-communicable and communicable diseases? Well, it's number 1. It's right at the top of the list. mental and substance use. And you can see this really compared to all of the other communicable and non-communicable diseases. And just for context, we see HIV/AIDS TB down here at number 15. Here's a figure showing disability-adjusted life years, or what we call DALYs, attributable to mental, neurological, and substance use disorders by age. These disorders contribute to reduced lifespan and excessive deaths. And note how the burden of these conditions rises rapidly in adolescence and peaks in young adulthood. This is very similar to the what we call the HIV bulge, or the burden of HIV disease that we're seeing globally. So I think it does speak to also the connections between the burden of these diseases and in the context of HIV. And I'll be talking a little more about this in a minute in terms of prevalence of mental disorders among people living with HIV, but over 60% have some type of mental health disorder, or people estimate 50% or more. Okay, yeah. Now let's talk about mental health and prevention. Mental illness, indeed, it's clear that it's a risk factor for acquisition of HIV. It contributes to 4 to 10 times increased risk for acquiring HIV. For example, if we look at the HIV prevalence among people with serious mental illness, and I'm looking at Fran Kronos, as well as Daria and Karen. I mean, these were pioneers in really pointing to this in the very beginning of the epidemic, 2 to 6% relative to the general population of the United States, which is only about 0.5%. And then more importantly, when we look at what we often say triply diagnosed, or mood disorders plus alcohol and substance use and other conditions in the context of HIV, it's even a higher risk. So for example, you see here how with these co-occurring conditions, that the probability of staying HIV negative, I don't know if you can see, did you take the pointer? Does it have a pointer on the? Well, you can see 0, 1, 2, 3, 4 of these conditions, things like depression, alcohol use, stimulant use, polydrug use, childhood sexual abuse. When someone has increasing amounts of those conditions, significantly goes down their probability of staying HIV negative. So it contributes to prevention, to HIV acquisition. Here you see portrayed in these two charts. This Bing study, 2001 in Archives, is old, but I'm surprised at how it is still often referred to and cited, because it was such a good study in terms of looking at people in care across the United States. It was a large study. And you can see the relative rates of these disorders like depression and anxiety, including panic attack, drug use disorders, how much higher they are related to the general population. On the right here, we see the rates among sexual minority men at the Urban Health Center. So this is among MSM, and you see these elevated rates of these disorders. Here's another way of looking at this across a lot of populations. You see the rates of these selective disorders are considerably higher among people living with HIV compared to the general population. I want to draw your attention to the largest disparities that we see here, particularly among lifetime alcohol or substance use disorder and lifetime PTSD, as well as current depression. And you can see the radical disparity between people living with HIV and the general population. Now, without showing all of the data, it's hard to capture globally because of the studies that are done differently in different regions. But basically, these rates are comparable when we look across the globe. In South Africa, for example, 26 to 38% of people living with HIV have a mental health disorder versus 13% of the general population. And as I mentioned earlier, and I think important to keep in mind, with all of this, we see even higher rates for adolescents and young adults. And Claude and others have certainly talked a lot about that. So why the high burden of mental health and HIV? I think probably everyone in this room knows this, right? The intersection of HIV disease and mental health is happening in the context of populations who are affected by multiple conditions. All of these factors, all of these conditions, including demographic, socioeconomic, the communities that people live in, even the environment in terms of conflict and water shortages and migration, biological, psychosocial support. All of these things are really factors that influence the prevalence of mental health disorders, what happens with that in the context of HIV, and how people are coping and dealing. And I want to point particularly to the intersecting stigmas, because, you know, we have, of course, we have HIV stigma. And I'm forgetting who gave the, someone gave a plenary early, a keynote. Someone did a historical at Croy talking about the early days of the epidemic that a lot of us know, a lot of us were there, and how intense the stigma and how blatant the stigma was. I would say in some ways the stigma that still persists today is a little bit more onerous in that it's not quite as overt and it's covert, but it's still very powerful and still there for HIV. We know there's stigma around mental health illness, and that's also very powerful. And then the populations affected are often feeling stigmatized because of some part of their identity, being a sexual minority or a gender minority, being someone who uses substances, or possibly being someone who engages in sex work. Now, depression is the most prevalent and most studied mental health condition in HIV, so let me focus a bit on depression for a little bit. Here, and some of these studies go back 15 years or more, that we see an effect of depression on mortality among people living with HIV. Here, there are some studies, large cohorts like the WISE cohort among women, and also globally in Tanzania, we're seeing mortality 6.6% among women with depressive symptoms as compared to 3.7% without depressive symptoms. And across these cities, we see women twice as likely to die as women with limited or no depressive symptoms, even after adjusting for certain predictors like CD4 count or duration of using ART or age. And similarly, in the WISE cohort, we're seeing 3 times the hazard of mortality on women on ART, 7 times the hazard of mortality when not using ART. So ART is effective, but even beyond that, there's something happening with depression. Here you see a dose-response relationship. This is a more recent study from Brian Pence, just actually published. It was published the week before I went to Croy, so I was able to work this in. With each 25% increase in days living with depression, untreated depression, we see a 19% risk of mortality. So it's a really nice, really well-done study if you want to look more closely at his data. So this, to me, raises the question of what are the potential pathways between mental illness and HIV health outcomes. And there are, we believe, potential biological mechanisms that are acting here. There's direct effects of depression on the immune system, which I think this is a really interesting, exciting area of study that we don't have very, very clear answers. But there is the chronic immune activation and HPA dysregulation. We know that HIV crosses the blood-brain barrier and that there's immune activation in the brain and the central nervous system. The inflammatory proteins lead to what we call oxidative stress and neuronal injury. And then we have this chronic inflammatory response to HIV infection. Rob's not here, but there are people around here, and Andrea's being focused on this kind of area. And I think there's a lot happening in the Psychiatric Institute, independent of HIV, around these areas. But we see things like elevation in level of cytokines, such as interleukin and TNF-alpha, which then trigger a chain reaction involving tryptophan depletion through the activation of IDO enzyme. And tryptophan depletion reduces serotonin levels, increasing kynurenine and its metabolites, and these metabolites are known to be neurotoxic and are associated with depression, suicide, and anxiety. So, again, I think, not my area of expertise. It's certainly an area of expertise for a lot of people, but I think this is an important pathway. Now, more along the lines of the work that a lot of us do and that I do, we know that the behavioral pathway is quite clear, right? So mental health impairment contributes to increased risk behaviors in HIV acquisition, delayed or lack of testing and getting into care and initiating care, contributes to poorer retention in care, delayed or lack of ART initiation, as well as poor ART adherence. All of this is really quite well established. and all lead to non-optimal HIV treatment and thus poorer health outcomes for the self, also for the community in terms of onward transition if people are not having suppressed viral load. And whatever the pathway, it's clear, whatever the pathway, biological, behavioral, likely both, it's clear that we need to address mental health problems if we want to improve all of our outcomes along the HIV prevention and the HIV care continua. Just further in digging into a very specific part of the cascade, the adherence part towards the end, this connection is very clear. There's a very strong body of literature and research around this. Here you see a couple of very large meta-analyses and reviews with large samples, 95 independent samples on the left, 111 independent samples. And in both cases in these large studies, depression significantly is associated with non-adherence to antiretroviral therapy and treatment. And it's been consistent across whatever the study design and adherence rates. When we look at people's own self-reported barriers to adherence or reasons that they struggle with adherence, this is representing over 19,000 patients across 125 studies in 38 countries. We see some of the self-reported reasons, including depression and feeling overwhelmed, stigma or secrecy, and alcohol and substance misuse. I've been focusing on depression because it's the most studied and the most prevalent in the context of HIV, but in the context of these co-morbid vulnerabilities that I mentioned, things like we know unstable housing, food insecurity, domestic violence, history of trauma, discrimination. There's a wide range of psychiatric problems are found among people living with HIV. So beyond depressive disorder, we see anxiety disorders. These are the most common. You can see any mental health disorder among someone living with HIV. But the most common are these: alcohol and substance use, post-traumatic stress disorder. And I would also say that these symptoms may or may not be associated with a diagnosable mental health disorder, but these are symptoms that are often cited by people living with HIV that they're struggling with, I think deserving of attention in their own right because they're distressing. We have somatic problems such as insomnia, pain, fatigue, sexual dysfunction, and non-somatic problems such as hopelessness and shame. So what about screening and treatment? Well, just broadly looking at the mental health field, here we are in the Psychiatric Institute. We're in the Department of Psychiatry. We have a wide range of effective interventions, psychotropic, psychopharmacological. We have a wide range of psychotherapies that are effective in treating mental health disorders, including CBT, motivational enhancing therapy, IPT. We have a range of stress reductions and mindfulness interventions, and mindfulness becoming even more popular globally. And of course, we have harm reduction and abstinence treatments available for people dealing with substance use. Majority of these are manualized, they're tailored, they've been tailored to different cultures, to different languages, capable of being scaled up. Technology more and more is being used as part of that scale up. So there are treatments out there to treat mental health problems. Similarly, we have a wide range of available screening tools. And I'm just showing you an array of screening tools that these are all validated. These have been used. Pretty much all of these have been shown to be reliable and valid in the HIV context in low and middle income settings. So we have the tools to screen and diagnose. Further, we have the tools to treat. So how are we doing diagnosing mental health conditions and treating them? Not only here in the United States, but across the globe. This is, I think, a really interesting study, again, from Brian Pence. And, is this the one? Oh, yeah, it is. From Brian Pence and his team. He took, the HIV cascade. We talk about diagnosing, identifying, getting to care, getting on treatment, achieving viral suppression. Here, if we look at the population, this is based on a lot of data across the U.S. and healthcare settings. And he really pulled a lot of data in this study to show us that of the prevalent cases of depression, less than half are actually diagnosed or recognized clinically. And then we have a further drop-off in terms of those people receiving treatment. and then even a further drop-off of really getting adequate treatment and follow-up, to the point where this study shows that 6% of people with depression are actually achieving remission in their use. And then we know that among youth, after the most recent school shooting, this is from the pediatrics group. It was drawn to my attention because on the NBC Nightly News, they were highlighting depression in adolescents. And the fact that as many as 2 in 3 youth with depression are not identified by primary care clinicians and fail to receive any kind of care. So, we're just not doing very well treating mental health disorders, and depression is the example that's being used here. Further, why are we maybe not doing so well? You look at mental health budgets, they're significantly underfunded. Here you see the disparity between low, middle-income countries and high-income countries. But what I really want to draw your attention to is not only the disparity across these regions, but if you look at how much is spent on mental health care compared to total health care cost, it's less than 1% of our costs going to mental health care versus all of health care. So again, I think that we're just globally, and including in the U.S., we're not doing as good as we can about paying attention to mental health and treating it. Similarly, we look at availability of mental health care providers being inadequate. Again, you see the disparities from the low, the first and second and third blue bar, these low middle-income countries versus high-income countries. But look at and this data comes from WHO and World Health Bank. Look at the examples of South Africa. 1 psychiatrist, psychologist per 1.5 million people. Or in Zimbabwe, 12 psychiatrists, 16 psychologists per 13 million people. And even, I think all of even in this country, people have trouble finding and getting to affordable mental health care. So it's a problem. So here's our reality. I think the majority of people, 70 to 85% with mental disorders across all country settings, do not receive adequate care, the care they should be receiving. We have factors like human resource shortages, fragmented service delivery, lack of capacity and policy to address this. And then, unfortunately, as I mentioned before, the stigma of mental illness is really still powerful at all levels among patients, among providers, in clinic settings and community-based settings. I'd like to think that the mental health, the HIV field can help lead the way in this, because I think this is across all diseases that, if people are going for diabetes care, for cancer, whatever they're going, annual physicals, they're not being assessed in terms of their mental health conditions. But I think we have good examples in HIV. So I mentioned earlier about how along the cascade we have mental health influencing the outcomes. The point of this particular slide is showing that we have opportunities for intervening, for conducting screening and intervening. In the beginning, when people are accessing STI diagnosis and care and treatment, or being offered PrEP, I think we need to do some mental health screening and attention to it there before they even enter the HIV treatment cascade. But certainly upon testing for HIV, upon diagnosis, when first accessing care, throughout care. We say this about adherence. It's a dynamic phenomenon. Mental health changes, is dynamic. It's not static. Because someone may be okay and not suffering from depression at one point doesn't mean something's not going to happen in their life and they won't have it along the road. So ART is a lifelong treatment. So in a way, I think we have to think about how we are screening, paying attention to mental health problems, whether it be an actual disorder or even just distress. I hope in the discussion we can talk about these opportunities and what are some models, what are some ways of intervening in clinics, whether it be private practice, in clinical care, in community centers, domestically and globally, how to more effectively do this. So let's look a little bit about what we have regarding effective treatments of mental health problems among people living with HIV, what's in our toolbox. Here I'm representing actually three large systematic reviews and analyses of mental health and behavioral disorders. And these are comprehensive reviews. There's this representing 181 studies across all income level countries with over 20,000 patients being representing all populations, adults as well as adolescents. And you can see there's a fairly wide range of intervention intensity and duration, as well as a wide array of intervention types that were part of these reviews. This is a summary of a lot of data, and you'd have to read these long reviews to really dig into it. But this is my takeaway. Generally, we see small to moderate positive effects. Of course, some have stronger effects, but overall. The biggest effects are with the lengthier and multi-level interventions. And I hear some chuckles. I'm going to talk later. We're being asked for what's the brief intervention. Give me the 2-minute screening and give me the 1-session intervention to treat. Well, we're more effective in our treatments if they're multi-level and have longer duration. Interventions that are primarily focused on mental health and also delivered by mental health care professionals are the most effective. So this is where we have people trying to do behavioral interventions and thinking, okay, I'm going to just do these 3 sessions and that's going to treat their clinical disorder. Well, you have to focus on the mental health disorder and treat it appropriately for that to be effective. We do see a lot of CBT components that are consistently effective in this review, as well as psychotropic and other HIV-specific health psychology interventions generally effective. But of course, the results are always mixed. So here's another way of sort of showing ways of integrating mental health screening and treatment and the benefits of doing this, and the model of care, the benefits of mental health screening and treatment. Essentially to say in this that if we reduce distress and stress in people's lives and their mental health symptomatology, if we work on reducing substance use and sexual risk behaviors, improve coping strategies, we can improve adherence to care and treatment, thus increasing achievable viral suppression to improve health outcomes for the infected individual, as well as reduce ongoing HIV transmission. So talk a little bit just about the models of task shifting and task sharing. This is, essentially, it's just basically treating non-professionals to deliver, what an otherwise professional would do. This is not just in mental health field, it's in other fields as well, but we're talking about in mental health. And the concept of integrated care, which, I hope in the discussion, Fran and Karen, Daria particularly, and there's a lot of work of the ATC around the model of integrated care, how best to do this. I'll just simply comment that I think it's well established, we know, that the basic referral or consultative model is probably the least effective. More often than not, if someone is just handed a referral and said, okay, it's 10 blocks away or it's in another part of town or, go ahead and make an appointment, more often than not, they're not going to get there. Even when it's co-located, though, under one roof, it could be just as much of a barrier to get from your primary care, from your nurse practitioner, to the psychiatrist or psychologist who's down the hall and around the way, who you can't just simply walk in. What we talk about integrated care is it includes like what we call a warm handoff, actually making the connection. And there being ongoing communication between the mental health care provider and the primary care provider. That's the kind of model that we talk about when we talk about good integrated care. I'm going to focus on just a couple of examples of, I think, some good studies showing what's happening globally with our scale-up and how, in the context of HIV, we're attempting to do this. So in this study by Glenn Wagner in Uganda, and his team, this is a clustered randomized control trial of 2 task-shifting models to facilitate depression care delivered by medical providers in 10 HIV clinics in Uganda. The providers being primary care provider, physician or physician assistant type of person, or a nurse. And without getting into all the details of the methodology of the study, essentially providers in both models received the same training of how to screen for and treat depression in this case. However, the nurses were trained using a systematic protocol, a structured protocol that guided them through all of this for the screening and the treatment. Whereas the trained primary care provider, again, same training, they were really just, they didn't use the structured protocol. They were left to their own clinical acumen, is the label they use. Their own discretion as to whether to pursue a full diagnostic training after doing some screening and to actually deliver antidepressive treatment. So essentially you see some differences and you see actually better outcomes with the use of the nurses with the structured protocol. But overall, the study really concludes that this existing staff, this is not bringing in new staff to the clinic. The nurses and doctors that are there can provide quality depression care. They say that they can do this with relatively limited funding for training and some ongoing supervision, like visiting occasionally by a psychiatrist or someone available in the setting. And that both models were widely adopted by providers in depression care. And most of the depressed clients actually received the care. So there's promising things like this. I'd like to use some of our own work, the work that we do collectively in a team, many people here in Massachusetts, and not focusing on the overall intervention, but in this intervention, we specifically trained lay counselors to be able to appropriately screen for psychiatric distress and alcohol and substance use problems. So we built into I think most of you know, it's a laptop or a tablet-based intervention. Counselors are just trained to use this. It guides them through all of their counseling activities. And what happens when they're first with the patient is what comes up in their first session is the standardized tools, screening tools, for screening for psychiatric distress and alcohol and substance use problems. What happens is they simply have to tick off the responses they get from the patient, and the tool automatically gives them a score and actually gives them a script depending on the level of severity, so that they know, like, well, you're having mild problems, maybe if you'd like to talk about it later, we can talk about it. But if it's moderate or severe, it's a stronger message that they deliver to the patient. I see that you're having problems, and either I can offer you, or if it's severe, they say, I am going to give you a referral. This is in the context of standardized care. There is 3 to 4 sessions, so we developed Massachusetts to match what the standard counseling delivery is for patients and their treatment buddies. Up on the right there, you see someone who is a counselor just grabbing a space in a very crowded clinic to work with her patient and the patient's support partner to go through the activities. And there are a lot of activities teaching them about social support, about barriers to adherence. There are videos talk about stigma and social support. But in the context of this presentation, this has all been very acceptable and feasible. We have studies published around this. But the mental health screening and referrals, we see a radical increase in comparing our Massachusetts counselors to the standard of care counselors. So when we look back into the charts and how often referrals were made, it was, is Ruben here? I forget these, 3 times, 4 times, 5, it was like, but the point being, it rarely happens in standard care. Even in standard care counselors, they're all told, mental health problems are important and you really should ask people how they're feeling and make referrals, because there are psychologists and psychiatrists that come and visit these clinics. But it's near zero that it happens in standard care. Because we built this into the intervention, it was done consistently, and a lot of referrals were made. Now, and with Massachusetts, we're seeing increased ART initiation and viral suppression. But I have to admit, we're challenged to really assess what's done with those referrals. We still have teams looking into the charts and the follow-up, but often it's not noted whether they ever got to a psychologist or a psychiatrist or a counselor of any kind. So this proves that you can standardize the screening and make it happen more often. We're still challenged by actually delivering the treatment. That's my point. I want to talk a little bit in this sort of more latter part of the talk about intervention intensity level. So I commented before when I showed you that meta-review that the more multi-level, the longer duration, the better the outcomes. But there's an increased focus and there's an increased demand for brief interventions. there's evidence for some success with certain brief interventions with some populations, but also, to repeat, there's also a lot of evidence for longer and multi-level interventions generally having greater and longer lasting benefits. So that's our reality. So the issue of level of intervention intensity, it's going to have to vary, I think. I mean, I think this is pretty obvious, depending on the severity of the problems and the level of need for any particular patient, right? And I think here's where we can do better in terms of figuring out ways of triaging people or having a step care approach to figuring out how to deliver. Here's a study that I'd like to highlight because of its intensity of care. Jamie, were you part of this study? Because it came, I thought your name was on this. Anyway, this is an example of working with severely mentally ill patients. Now, these are patients who have substance use disorders, HIV, some kind of mood disorder, and some of those co-occurring conditions, trauma and things going on in their lives. But look at the intensity of the intervention. And this is the center of it are these advanced practice nurses. You have a year of in-home consultations, coordinated medical and mental health services from these nurses, collaboration with prescribing providers, pharmacists, case managers, helping organize people's medication regimens, addressing their own personal barriers to adherence, promoting their ability to self-care. There's an intensity here. There's a lot of attention. Minimum of 1 week meeting with a participant, psychoeducation pillboxes, beeping watches if they need them. And then there's also ongoing monitoring so that if someone falls less than 80% adherence, you've got this cascade of intervention where you'll work more closely with them, maybe reach out and work with their social networks, even doing things for some patients, giving them prepaid cellular phones. If needed, if all else is failing, directly observe therapy. So this is an intense intervention. They have very good outcomes in terms of reduction in viral load at 12 months and significant change in viral load, CD4, and health-related quality of life over 2 years, 24 months. So I think for us to think about is what proportion of the population needs this intensity. Is it there was not done, and I think there needs to be done, cost-effective analyses of what does it mean with these very hard-to-reach patients that I think most of us experience. The providers will throw up their hands and say, I've tried everything with this patient. I give up. I can't do it. Well, if we don't give up, you probably can do it. What's the cost-effectiveness of getting that person to viral suppression versus not? So please, let's think about that. Let's talk about that in the discussion. Here's another example, a very recent example, and this is just a pilot study. But NIMH's colleagues are very supportive of this kind of work. And the reason I'm showing it, and you don't have to read all of these, is that this is another example in the context in Zimbabwe of it's an example of what I'm calling a step care approach with some kind of algorithms and measurements along the way. I can't even read that up there. Let me blow this up here. Just so that you can see that what's happening along the way is they're screening for depression and evaluating and screening for adherence problems and monitoring people. And then they integrate boosters for people who need it, depending on where they're falling and what their needs are. And so if they're above a certain cutoff or below a certain cutoff, they'll get options to intensify the intervention all along this pathway. So it's not quite as labor-intensive and with providers as the one I just showed you. This is more in the context of a low-income settings, where, again, you have acceptability and feasibility of doing these things, but doing it in a stepped approach for those who need it, giving them more. I think too often a lot of our interventions that we study and the RL1s that some of us get, you have to sort of deliver the same intervention to everyone. You have to have a comparison group, and then you look in the aggregate, how well is your intervention do versus standard care. I think where the heart of the work is not everyone's going to need the intensity. Some people are going to benefit from those 3 sessions. Maybe the majority of people, but not the rest of the people. So given the resource reality, we have to ask, look at the challenges of scale-up, of addressing the mental health need in the context of ART scale-up. I mean, those of us who work in South Africa, other sub-Saharan African countries, I mean, they're just, thousands and thousands and thousands of more patients are being put on ART. But, how do we address these other problems along the way? It's going to look different in different regions, and that depends on a lot of things, including political will and local policy and how much advocacy is in this setting. But there's a spectrum of mental health impairment from distress to, 1 disorder to 3 or more disorders, a greater intensity of severity of disorders. And I think we need more of these stepped intervention approaches and actually more algorithms and tools to decide, and figure out who's needing more, when and where they're needing it. I want to talk a little bit about who's heard of U equals U. Not everyone in the room? Undetectable equals untransmittable. And this is becoming a really growing, powerful message that emanated from the community. It's supported by our science. Carl Diefenbach, from the head of DAIDS, and Tony Fauci, I heard him talk recently, they support this message. They say the science is there. If someone is really sustained viral suppression, they can't transmit the virus to their sex partners. And the evidence is not quite as clear, but there's evidence that, or IDU partners as well. Okay, so if you get a sustained viral suppression, and so when I say coming from the community, they're talking a lot about how this ideally will build hope in the community and also contribute to the ending of HIV stigma in terms of, being an infectious agent if you're someone living with HIV. And I'm bringing it in here into the context of mental well-being. I'm not proposing U equals U. I'd like to label this an intervention campaign that I think should be studied in terms of its impact. But these are actual quotes from people in New York State. I'm doing work with the health department around the ending the epidemic and the task force, and there's money behind this campaign. And so in these meetings and when we go out to the community, we hear things like, HIV made me feel unattractive and made me feel afraid to have sex with my husband, who is HIV negative. Since I learned about U equals U, I have lost 20 pounds, I feel sexy, and my husband and I are making up for all the times we missed. When I learned I was HIV positive, I became isolated and depressed. I went on medication, but knowing I had the virus made me feel dirty and ashamed. I stayed that way for 7 years, stigmatizing myself. U equals U has given me my life back. Knowing that I can't infect anyone else has allowed me to forgive myself. It was only when I learned about U equals U that I realized that I had been living for all these years carrying this heavy weight. Because I took my meds, I kept on living, but inside I felt like I was dying, and that made me afraid to get close to anyone else. The night I heard about U equals U, I couldn't stop crying. It was like that burden I didn't even realize I was carrying was lifted. So I think that, like I just said, just to emphasize, I think there's a research agenda here. I think some of us should brainstorm and think about, how to study this. It's a movement. I think the time is right. What is the impact on people's experience of stigma, but also on their psychological well-being and their psychological state and level of distress? If you read these quotes, there's some indications there that it improves quality of life and feelings of well-being. So I'd like us to study that a little bit more. This brings me to and reminds me of a paper that Claude and I wrote back in 2007. And I'm proud of this paper because it's been cited a lot. And I think we wrote it back then when there was sort of in the more earlier stages of all this intense scale-up of ART globally. and everyone was just looking at like, we've got ART, we've got it in these countries now. It's affordable. It's like South Africa. Let's just give it to everyone, and everything's going to be okay. And so what the message in this is, let's not forget the individual in our global response to the pandemic. And in this article, we talk about the things I've been talking about, the reality of the lives of the people living with HIV and what they're coping with, and the attention that's needed all along the way. So I just like showing this and highlighting this. We know, and this room certainly knows, in terms of all of our interventions, and even in some of the screening, we need diversity and tailoring. Whether we're talking about young people, adolescents, we're talking about gender differences among women, among men. And I'm not getting into it now in this presentation, but there is diversity and tailoring. We know that a HIV-positive mother of 3 living in sub-Saharan Africa dealing with PTSD will have different needs from a young HIV-negative black man in the southern United States, kicked out of his home for being gay, suffering from depression, or a 40-year-old transgender woman recently diagnosed with HIV, suffering from an acute anxiety disorder, 20-year-old heterosexual man in Central Asia, maybe Kazakhstan, coping with opioid addiction, still have unknown HIV status. So, it goes without saying that we have effective interventions, but, there's also just the level of care and listening to people and the attention that you need to tailor your approaches and your communication and being culturally sensitive to the different populations. So what are my take-home messages from all this? Mental health matters. We see mental health problems ranging from distress to serious mental illness. We see that they're elevated among the population of people living with HIV, as well as those just affected by HIV, vulnerable to HIV acquisition. They contribute to HIV acquisition, as well as clearly we know poorer health outcomes all along the treatment continuum. We have the toolbox. We have the necessary screening tools if they were used efficaciously. We have effective treatments, but we need to prioritize mental health treatment in all settings. Addressing, I don't know how we in the room are going to address the resource gaps and change the world in this regard, but I think let's think of ways of doing that. I think in the HIV context, promising advances are being made, integrating mental health care into primary care with some of these task shifting and step care interventions that I gave you a few examples of. That's why I talk about, maybe HIV can be one of the medical domains where it sort of leads the way, as we've done in other aspects of medicine. I think I said it at the outset, I think integrating mental health screening and treatment into HIV care should be routine. I'd like us to talk in our discussion about how to do this and when and how often. In HIV care, people have to come get their viral loads checked. It keeps changing. Here it's still about every 3 or 4 months. Should it be every time they're getting their viral load checked, someone gets a screening to see if their mental health condition has changed? Or at least in general care, once a year and an annual. I don't know how many people, if you go for your annual physical from your primary care provider, do you get asked questions about your mood or substance use or your drinking or things like that? But in HIV, let's think about where and how to do this routinely. Because as I said before, ART is a lifelong treatment. It's not a one-shot deal. I think we need stronger advocacy for the human right to the highest attainable standard of mental health, which is urgently needed. As I said at CROI to the entire audience, I hope everyone can be an advocate for this and just advocate for this. And I think, again, the HIV field can lead the way. So let's do it. I'd like to really thank all of these people you see here who really had an influence on this study, including sharing of slides, particularly my good colleagues right here at Columbia and HIV Center, Claude and Nadia and Ruben and Andrea, Javier, Francine and Milton and Karen, as well as my NIMH colleagues. They were very helpful, all of these people, Mike Sterrett, Diane Rouse, Chris Gordon, Terry Sen, Greg Greenwood, and really helped shape this and shape the messages that they wanted to put out there. So as I, looking at laughing Claude, as I close with Croy, I also want to close with you because, clearly no health without mental health. That's a nice quote we like to use. But the work that we do is challenging. It's not easy. I mean, whether it be our research or our advocacy work or our care and what we do with communities. I mean, we chose to do this kind of work not because it's making us rich. And I hope it's gratifying to all of us who do it, but it's hard. And whether it's be working hard to get grants or working hard with our communities to deliver care and to try and change policy and problems that are out there. So my message to you all personally is, take care of your own bodies and minds. Exercise in the outdoors as much as you can whenever possible. Eat healthy. I don't mind sounding like your mothers. Get plenty of rest, sleep. This is my biggest struggle. Don't forget to stop and smell the roses. Take time for yourself. Expand, relax your mind, stretch your bodies. But most importantly, let's always support each other in the work that we do. Thank you.